Good morning and good evening, fellow doctors and colleagues. For today's Dr. Sheng-Po retirement virtual webinar, we are honored to introduce Professor Wojciech Golusinski as our invited speaker. Professor Wojciech Golusinski is the chair of Department of Head and Neck Surgery in Poznań University of Medical Science at the Greater Poland Cancer Center. He is also the past president of the European Head and Neck Society and the initiator and founder of Polish Head and Neck Society. Professor Wojciech Golusinski has published more than 300 papers, reports, and lectures published in Polish and foreign journals. His specialties interest is the role of HPV virus in cancers of the oropharynx, as well as genetics and molecular studies evaluating the biology of head and neck cancer. Professor Wojciech Golusinski is an initiator, author, and organizer of National Head and Neck Cancer Prevention Program. In 2016, he was appointed to the position of expert in head and neck cancers by the Polish Ministry of Health. For many of years, he has been the most recognizable Polish ENT surgeon dealing with the head and neck cancer treatment in Europe. Today, Professor Wojciech Golusinski present topic is basic research in the field of head and neck surgery, connection between the hospital bed and a lab. Please give a round of applause to welcome Professor Wojciech Golusinski.
Good morning, everybody. Esteemed Dr. Sheng-Po, dear my friend, dear Taipei, I would like to express my administration for your fantastic work for the global development of head and neck oncology. You are well known in our head and neck community. Your personal influence on the connection between our international family is enormous. For me, it's a great honor and privilege to deliver my presentation today. All the best for you and your family, and my dear. I teraz zaczynamy. Chciałem będzie tylko prezentację. A co kiedy? Co?
Też tam profesor mówił, tak?
Proszę?
Tam profesor też mówił, tak?
Okay.
No slajdy pan wysłał,
Tak, tak. Dear Dr. Sheng-Po, ladies and gentlemen, my lecture today is about the basic research in the field of head and neck surgery, connection between the hospital bed and the lab. I think that is a very important messages for all of us, especially for our patients. And the beginning in this world rise three crucial questions. Firstly, is basic research important from a surgeon's perspective? Secondly, can basic research improve the clinical surgical management of patients? And finally, should basic research be implemented in clinical practice? We know very well that we have the 5 pillars of oncological care: diagnosis, surgery, radiochemotherapy, systemic treatment, targeted immunotherapy, and rehabilitation. And which pillars are particularly important for basic research. My opinion, for basic research, the two most important pillars of oncological care are diagnosis and systemic treatment. In diagnosis, the focus should be first and foremost on tumor biopsy and laboratory tests, including tumor markers, genetic tests, and follow-up. And secondly, the systemic treatment, we should concentrate on targeted approaches to inhibit molecular pathways that are critical to tumor growth and maintenance. And we know everybody that it's a lack of the blood circulating biomarkers for the head and neck cancer. We have a very good examples of the other cancers, like for example, prostate cancer, breast cancer, lung cancer, but unfortunately, we haven't yet very well established the blood circulating biomarkers. And the same is the situation when we take into consideration the tissue genetic changes. You can see that we have some well-established genetic changes like cancer, ovarian cancer, breast, liver, prostate, but unfortunately, we haven't in head and neck cancer. And our focus, our research, definitely, we have to thinking about these two main target to establish the circulating blood biomarkers and tissue genetic changes in the head and neck. And regarding the head and neck, we have many biomarkers have been suggested to significantly impact diagnosis and prognosis, and few of them have been validated for use in the clinical practice, especially HPV. The detection of HPV DNA in saliva samples has been shown to be a predictive tool for recurrence in HPV-associated oropharyngeal cancer. And immunoscore, in recent years, it has been well established that the immune system plays a pivotal role in the control of tumor growth, and has been suggested that potentially invading cancer cells are held in equilibrium state that is controlled by the immune system. There is need for the development of immunological biomarkers that can offer prognostic information and facilitate clinical decision making. PD-L1 expression was shown to be associated with the rate of response to immune checkpoint inhibitors and was therefore established as the most commonly used predictive biomarkers. And also, the next generation sequencing offer the opportunity for molecular characterization and has therefore expanded our knowledge of genetic profiles in a variety of solid tumors. And this is very well known. Pictures the progression of head and neck squamous cell carcinoma and key genetic events. And you can see we have the two stages, early stage, late stages. In early stages, this the normal mucosa, hyperplasia, dysplasia. In this early stages, the most important is inactivation of tumor suppressor gene as CDKK and 2A, and in the late stage, inactivation of tumor suppressor gene as 10. And also in both in early and late stage, and loss of heterozygoticity is a common genetic event in cancer development and can be caused by degradation, deletion, due to imbalance, rearrangement, gene conversion, mitotic recombination, or loss of whole chromosome. And I think that it's taking into consideration all this information. We have to know that there is a lack of commonly used biomarkers of head and neck carcinoma and diagnosis, monitoring, treatment response, and long-term follow-up over decades. Why? I think that we have different problems and with the head and neck cancer. Firstly, is the high histologic and genetic heterogeneity of our tumor. Secondly, different in anatomical size within head and neck region. Third, the impact of HPV and EBV oncoviruses, head and neck squamous cell carcinoma development. And fourth, determining in one precise biomarker may be used for all head and neck cancer types. And the worldwide trends of head and neck studies, including, in my opinion, and the three main topics, is the firstly is to HPV-related studies. Secondly, tumor microenvironment and epidemiology, and the third, identification of cancer cells and DNA from tumor liquid biopsy. And this is the number of the publication of these three fields. You can see HPV-related studies in the last decades, and it's many publications, the same in about the tumor microenvironment and immunology, and also in about the liquid biopsy. This is the worldwide trends in the basic research in head and neck field. And firstly, I would like to say something about the HPV-related studies. That it's any doubt that it's HPV-related head and neck tend to occur in younger age groups with little exposure to the tobacco and alcohol. And the epidemiology studies show us that approximately 31% of the oropharyngeal cancer and oral and laryngeal cancer can be etiologically attributed to HPV infection. The patients with HPV positive head and neck seems to have significantly improved response to chemotherapy and radiotherapy as compared with HPV negative tumors. And HPV is closely associated with poorly differentiated cancer, positive lymph nodes, and late-stage disease, which all indicate a poor prognosis. And what is the most important is the detection of HPV-driven head and neck squamous cell cancer. And several procedures have been fully developed, validated for the screening of pre-malignant and malignant cervical lesions. And you can see that with several factors, then they may influence of the efficiency of HPV detection. Firstly, the type of samples, frozen, formalin, for example. The second, the sensitivity of HPV testing method is P16 histochemical staining, DNA in situ hybridization, HPV DNA polymerase chain reaction, PCR, HPV protein E6, E7, mRNA detection, quantitative reserve, transcription, PCR. The HPV detection rate is usually higher in frozen biopsy samples than in formalin samples, and also the oral scraping are not reliable for detecting HPV method. And finally, the HPV testing methods are mostly based on detecting HPV DNA in cancer tissue, either with the in situ hybridization of PCR or both. And currently, there is no consensus on the most appropriate method of detecting HPV in head and neck squamous cell cancer. Many studies have focused on establishment of algorithms that could result in rapid classification of head and neck. And the concepts are being explored for possible diagnostic algorithm and using the combination of direct and surrogate serologic markers of oncogenic HPV infection in flesh and tissue and paraffin samples tissue. HPV biomarkers is in body fluids can be used in combination with diagnostic algorithm for early diagnosis and follow-up head and neck. And possible HPV biomarkers we can follow plasma, serum, and saliva. And secondly, the very wide topic is the tumor microenvironment and immunology. And the tumor microenvironment is made up of several important components. Both initiate and adaptive immune cells play a crucial role in mediating immune surveillance and controlling the tumor growth. And why is the tumor microenvironment is important? Because the tumor microenvironment has been recently reported to play a pivotal role in sustaining tumor cell survival and protecting them from immunotherapy and chemotherapy-induced death. And it remains largely unknown how the specific signaling pathway exerts the tumor microenvironment in head and neck, the regulatory mechanism involved in tumor environment, stromal cells, tumor angiogenesis, and cancer stem cells. And these components are responsible for tumor progression as well as anti-cancer therapy resistance, leading to rapid tumor growth and treatment failure. And now we know some drugs targeting to the TME of head and neck clinical trials. You can see many studies is ongoing, and the TME component in head and neck treatments is the combination with the different drugs and different checkpoint inhibitors. And we also in our lab provide some study about the tumor microenvironment, and our aim is to determine the gene expression of selected senescence associated secretory phenotype in head and neck cancer patients. And in our study, we would like to focus on the interleukin-6, interleukin-1B, CXCL1, and TNF, tumor necrosis factor alpha, is an inflammatory cytokine produced by macrophages monocytes during acute inflammation and is responsible for a diverse range of signaling events within cells leading to necrosis or apoptosis. And our results the rock curves showing that senescent cells biomarkers with the potential is distinguished tumor tissue from nearby histopathologically unchanged tissue in oral and laryngeal cancer. And current status of the future of the tumor immunotherapy from head and neck squamous cell carcinoma, and summarize that you can see that emerging tumor immunotherapy is an important role, important method for treatment of head and neck squamous cell carcinoma. Activating an effective immune response can impair the phenotype and function of tumor cells, killing malignant cells and triggering an adaptive immune response. And however, immune escape caused by multiply mechanisms that limits the immune system from recognizing and attacking tumor cells. And how it looks nowadays, the different methods of immunology and immunotherapy treatment. We can use the different immune checkpoints inhibitors to the main immunotherapy, and we use the monoclonal antibody against the immune checkpoints. And the future is the cancer vaccine and oncolytic viruses, and we look in the future of the new possibility using the new methods and treatment for our patients. And immune checkpoints in head and neck. During the carcinogenesis, T cell activation is treated by a number of pathways which are often activated by the expression of certain ligands of tumor cells or antigen pediatric cells, and most of them is very well known, established, like PDL1 or PDL2, and they bind to receptors on T cells and inhibit the activation and the anti-tumor function of the cells. And completing neoadjuvant chemotherapy clinical trials, you can see how many trials we have adopted the immunotherapy in the treatment of the head and neck patients, and different drugs that we using the same checkpoints. And the last very interesting topics and very wide and very promising in the head and neck for head and neck cancer is the identification cancer cells and DNA from tumor and liquid biopsy. And I think that is very important stress that this liquid biopsy we can using the biomaterials like the body fluids such as blood, saliva, and urine, and these biomarkers are crucial for providing real-time information about the tumor, the change over time, and liquid biopsy can provide such information to support treatment strategies for oral cancer patients, and this method is very rapidly developed. And in our lab, in our study, our aim is to characterize the novel microRNA that are specifically upregulated or downregulated in serum of head and neck patients as compared to healthy donors. And liquid biopsy, like the potential in HPV positive oropharyngeal squamous cell carcinoma biomarker, and in this case, the tumor cells and tumor-derived DNA and up in the bloodstream that may function as a biomarker to facilitate personalized medicine. And the obtaining blood plasma and isolating the cell-free DNA and establish and by quantification method of PCR and make it possible to detect and quantify cell-free HPV-specific DNA sequence for diagnosis, therapy, stratification, and disease monitoring. And you can see the clinical trials incorporating circulating HPV DNA assessment. It's very fresh in 2023 in the US, many ongoing trials. And new perspectives of our study, we would like to have two targets, two aims. The aim one is the extraction of genes whose mRNA is specifically methylated, separating HPV positive and negative, and then the cancer and the validation in patients' cancerous tissue with statistical correlation to tumor progression and treatment response. And the second aim is validation of selected markers in cell-free RNA from liquid biopsy of head and neck patient and its expression correlation with treatment response follow-up. This analysis will lead us to indicate three epimarkers highly specific for each HPV subsite that will be sensitively need to change related to the development or recurrence of the tumor. And for the research for the young generation, for the head and neck oncologists, head and neck surgeons, we have to prepare special facilities for the conduction of the research. We have to learn a lot about the banking, tissue banking. In our department, we provide and we create the head and neck lab and the tissue banking, the patient's biological material we selected during the surgery. We took the cancerous tissue and tissue from the postoperative free margins, and also we collected the serum and the peripheral mononuclear cells. And we selected this material on the first day of hospitalization, during surgery, and follow up visit after the completion of the therapy. And take-home message summarized that we are in search of the novel biomarkers to predict and monitor treatment in head and neck, novel targeted therapies, novel biomarker for early and non-invasive detection of head and neck. The main aim is to describe in depth the mechanism responsible for head and neck progression and resistance to treatment. Thank you very much for your patience. And once again, I would like to stress this is a great honor and privilege to deliver my lecture and for my dear friends, dear Peter. Thank you very much.
Thank you for Professor Wojciech. Wonderful talk about the basic science in head and neck surgery, genetic and molecular diagnosis and treatment, which is surely the future of head and neck cancer. Now we open to the floor. Is there anyone has something to ask for the discussion?
Hello.
Yes,
My name.
yes.
Hi, I'm Petravut from Thailand. Thank you very much, Professor Wojciech. That's a great talk that you have given a very comprehensive view of the role of the basic research in head oncology. And yeah, even though still a lot more to do, but I think it's very convincing that in the near future, we will reach to the precision approach. I would like to ask you that with this direction on this basic research and the aim that we try to achieve with the precision that, firstly, how do you foresee that this would impact on the role of the head and neck surgery, because we are mostly a surgeon, and secondly, how I would like to get your suggestion. How do we convince the head and neck surgeons to involve or take a lead in this kind of research to contribute to the field?
Yes, as Professor Golusinski is not here online,
Oh,
so
okay.
Yeah, so probably I could answer your question. I think just in part, and in my opinion, well, your question is wonderful because we are all clinicians and we face the patient and we have to treat the patient. So I think the very important thing is that the head and neck surgeon also explore yourselves for this kind of basic and translational research, because if you have this kind of concept, then you will look at your patient, look at your patient's tumor differently. So and then you will be much more clear that the tumor you are facing or you are treating, not really every case is a surgical candidate. Probably you will think of more on how the patient should be treated, and then and how we could really early detect the recurrence, for example, and using some of the methods Professor Golusinski just mentioned, the liquid biopsy or some, and for HPV as instance, or for EBV as an instance, especially on EBV, some of the biomarker has been applied for the to predict the progression or even to predict the recurrence or the treatment outcome. So that really means the basic research could be translated into clinical management of the patient, and I think it's very important for the head and neck surgeon could also understand this and explore yourself into this, because if you really understand this, you will have a different view on the patient and on the tumor you treated. And the second question, as usually in the multidisciplinary care of the head and neck cancer, usually head and neck surgeon will be the the leader in the team, and I think we are still the leader, but it's become more and more a multidisciplinary care team. And then why the surgeons still here, still hold the key role? It's just that we are surgeons because we have the spaceman, and the spaceman, and we have the blood of the patient, we have the tissue, we have the cancer tissue, we have the tissue around the tumor from the patient, and who holds the tissue could build up a tumor bank, like Professor Golusinski and just share with us. So once you have the tumor bank, that's the start of all the basic or translational research. So, and for sure, you are the controller of the bank. you are the owner of the bank, you are the controller of the bank, and then you should take at least a very important role to lead all the game, because the game starts from here. And that's my response to Professor Peter Wood. Thank you.
Thank you very much, Peter, and I totally agree. Yeah, we would need to bring more and more of our head and neck surgeons to involve in this field. And once again, congratulations, Peter. And I appreciate your dedication to contribute to the field of the head and neck oncology, and sharing the great knowledge from around the world. This is a great opportunity. Thank you very much.
Thank you. Is there any other comments, or is Jimin, are you online now?
Yeah, Peter, sorry, I'm out, but I'm listening, yes.
Okay, and do you have any comments?
Yeah, I think from what you mentioned, I fully agree. That's why there's a track called the clinician scientist or surgeon scientist that's particularly valuable if you have somebody to drive that from a clinician scientist perspective, because the person will be familiar with both the clinical questions and then will be able to apply the translational research to address the questions. So I believe this is a track that hopefully the junior faculty will be interested to take up. The other part is certainly with surgeons, I think having the tissue biobank is very powerful and useful, so that he or she can then use this resource to serve the head and neck working group for translational research. Yeah, so I fully agree with your comments. Yeah.
Well, thank you, Chairman. Yep. Is there any more questions? And or Peter, do you have any comments?
First, you're muted. There is no sound.
So thank you again, Professor Wojciech Golusinski. I think your talk is wonderful because you bring insight into the basic research and also into the how we could translate the basic research into our clinical practice. And HPV is a very good model. EBV is a very good model, and also the recent development of immunotherapy. I think this also bring some light for the some provision young stars like Chumin or Petrobut that we should develop more and more, devote ourselves more and more into the basic research and translation research, so that we could move the head and neck oncology forward, and in not only in the diagnosis but also in the clinical management of the head and neck cancer. So thank you again for all the participants. And now we are going to have some broadcast for the next speaker. May I see the slide? Yeah, the next will be next week will be our friend Professor. Go back one slide, please. Professor Alfredo Pontejos, and he is going to talk about the classification of neck dissection, a better one, and that's from our very good friends, Professor Alfredo Pontejos from Philippines. And then can I have the next slide? And then that's the end of the April. And could we have the schedule in May?
We haven't posted yet.
Oh, you haven't. Okay. So look forward to everyone attend the last lecture, webinar lecture in next Monday by Professor Alfredo Pontejos. And thank you again for all the participants, and have a good day. Thank you.
Thank you. Have a good day.
Thank
Bye.
you, Peter. Thank you for your comment. Have a good day. Bye-bye.
Yeah, bye, Peter.
Yep.